high atop the Aubrey Plaza in beautiful downtown Wilmington, Delaware.
We are the Podcast Pediatricians.
I'm Matt Gotthold.
And I'm Rob Walter. Check us out on iTunes, Spotify, YouTube, and a whole bunch of other places as well. Of course, on podcastpediatricians.com. And as we said last time, again, Maddie, we are back. Hopefully we fixed the audio issues from that last episode. Maybe Matt turned on his mic this time. I don't know.
Well, it was a faux pas.
A little faux pas. So it is, spring is here. What is new, Maddie?
All kinds of stuff going on in my family at this point. How about you?
I got married. You were there.
You did, and I was.
It was.
Yes, it was quite the shindig.
It was a party.
High end, Rob. Very nice.
Thank you.
Yes.
All Susan.
Quality.
All
Quality.
Susan. High end.
Well, that was obvious, dude.
I didn't know if you were in the Hora or not. Were you in the circle?
I was not. Wasn't there in a timely fashion. Shocker.
I haven't asked you, but they put you up in the chairs, and I don't know if you did that, but whoever was on my chair was horrible. Susan had all these huge guys, and mine was like sideways, and I was like almost killing myself. I don't know. Did you notice my?
I was there for that, and I saw you teetering kind of precariously up there.
But I survived, and I moved to Pennsylvania. I'm no longer a Delawareanite.
I don't even know if I should be chatting with you. At this
I know. So the first shock of being a Delawarean was, in being a Pennsylvanian is in Pennsylvania you have to get your car inspected every frickin' year.
Oh my goodness!
Like to some kind of a gas station or something like that. In Delaware it's like every 3 to 5 years.
Yeah.
It's like free at the DMV.
Right.
And every Pennsylvania person says, "Are all the cars falling apart in Delaware?" And I'm like, I don't think so.
I don't think so. No.
It seems pretty scammy to me. And Maddie,
yes.
You have some nuptials coming up in the family.
I do. Not my personal nuptials, but my daughter Christina is marrying a fabulous young man named Stephen, whom we have fully embraced in our family. He's just a fantastic guy, and I could not be happier about that.
That's great. I have a suggestion for their honeymoon. Mexico City. It's the new place to go. The restaurants. It's unbelievably cheap on top of it, but it's like really a lot of LA people there. It was a direct flight. I went with my son. And the old days when you went and you thought, what if I get Montezuma's revenge and a GI issue? But that's taken care of. But it's not. We both
succumbed.
Us,
yes.
We tried. I mean, maybe we had some ice cubes. We went to nice places, but man, the last night there, because my son used to live there and he loves going to movies there. It's like $2. We went to see Sinners. Have you heard of it?
Oh, I have heard of it.
Oh my God!
I hear it's got a blues theme partially.
It does.
I do need to catch up with that.
And the history, you would love it, Maddie. Big Podcast Pediatricians thumbs up for Sinners.
Well, all right.
So hit us with a disclaimer, Maddie.
Okay. We are sharing our own personal opinions on pediatric care. Always talk to your own pediatric caregiver about your child. Pediatric caregivers should always consult expert guidelines and consider their own community standards of care.
So I just had my 40th official Northwestern Medical School reunion.
40th,
I know. And so
you're old.
And you get there and it's like it's run by the university. It's pretty boring. So I always try to do a little bit of a get together. So we went for deep dish pizza at Lou Malnati's, Second City Comedy. It was a bit chilly in Chicago, but have you been to Chicago in the spring?
I don't know
it's
that
gorgeous.
I have. Yeah,
it's gorgeous, and it's quick to kind of go back to your old personality when you were there. I was 20 when I started medical school. And, my classmates I was with, a cardiothoracic surgeon, a neurosurgeon, an orthopedic surgeon, a med school dean. But when you're with them,
so you're a slacker.
There's still the doofus who couldn't hold his beer at Streeters and played video game joust all day. Still that. Well, actually, that was just me. But
Shocker.
they still could be that guy. And then we had a mini pediatric residency reunion. It's been 40 years since our internship at Children's Memorial Hospital. So in that vein, the first paper I want to mention, which most people hadn't heard of, is from Laboratory Investigation last month. From my alma mater at Children's. It's now called Lurie Children's Chicago. And it strongly suggested that Kawasaki's disease is caused by a single respiratory virus. So we've discussed in the past that Kawasaki's is an uncommon but not rare condition. We all see it. That causes a combination of prolonged fevers, red eyes, swollen lips and mouth, enlarged lymph nodes, swollen hands and feet, a rash. But most importantly, it leads to cardiac issues and can even cause heart attacks in the kids that have it. The cause has always been a mystery. It was identified as a disease over 50 years ago, as you can think from the name, first in Japan. And oh my goodness, in the 80s, Children's was the Kawasaki's center. For those of us who are residents, it was like treating asthma. Unfortunately, we got to see multiple kids with heart attacks, which is not a usual pediatric thing. But the lead author of this study, Ann Rowley, was the fellow in ID when I was there trying to figure this out 40 years ago. And I think she finally cracked the mystery that, yes, it is a virus. We suspected that all along because it came in bunches, right? Remember, we'd come in bunches, just like an infectious disease, but we had no proof. But in her study, she used antibodies from archived blood cells of children with severe Kawasaki disease. I think most who didn't make it over 50 years in Chicago and Japan, including patients probably I saw in the 80s. And they discovered that all the samples had antibodies specific for the same inclusion bodies that are byproducts of a virus. And these inclusion bodies were in the medium-sized airways of the patients who died. So the virus that causes Kawasaki disease appears to be a respiratory virus. And this will hopefully lead to more definitive answer on which virus it is and more targeted treatments and tests. And it makes me think of Dr. Rowley's boss back in those days, Stan Schulman, Rama Yogev, and the ID Dream Team of the 80s.
Yeah, there just are not that many medical mysteries like this left, or at least it doesn't seem like there are, although every time we think we've figured something out, it seems to kind of turn on us a bit. I remember there was talk that Kawasaki cases seemed to be associated with living near large bodies of water.
Right.
So the thought was that maybe the source was a waterborne pathogen. And then later it seemed to be an epidemiologic connection to exposure to carpet cleaners, if you remember that.
We were asking, have you been exposed?
That's right. Have you cleaned your carpet lately? Right? By the way, Robbo, it's worth noting that in this time of defunding huge swaths of research, which only seems to be increasing, that the discovery of this link was in a university lab funded by the NIH. Imagine that.
Wow.
Yeah. We try not to discuss too much politics here, but I'm reading that more and more of America's most brilliant science researchers are actively leaving and considering leaving the U.S.
Yeah.
These researchers are no longer able to pursue their research here due to funding cuts, so they're being poached by other countries who respect the work they do. It's a brain drain for us, and it's insane.
Right.
Yeah.
The United States having brain drain.
Yeah. We've been the world's leader in medical research for decades. Why would those who govern us put us at that risk? Not to mention the potential unnecessary loss of life that may be the result of us not being able to continue the hard and dedicated work that has historically helped to save countless millions of lives worldwide, and particularly the lives of children over the last century.
Just the HIV.
It's
under George W. Bush that saved millions of lives, and that's in jeopardy.
It's insane. It's insane. So here are some other recent research papers of interest and that may not have been funded in the current status of things. So, hot off the press, this month, the May issue of Pediatrics contains a meta-analysis by Finch Edmondson et al. That reviews the use of umbilical cord blood to treat cerebral palsy. The idea of giving umbilical cord blood to children with cerebral palsy has been around for a while. This paper examined 11 studies and found that the use of umbilical cord blood improved gross motor function measure scores. This intervention appears to target disturbances in these children's developing brains and is thought to work through anti-inflammatory and immune-modulating actions, which actually promotes repair.
I never heard of that.
Yeah, it's crazy, right?
I never heard of that.
Rob, you and I have taken care of many children with cerebral palsy over the years, so this is really exciting to hear about the possible treatment for these kids. Generally, the approach involves early intervention therapies that involve things like physical therapy, occupational therapy, speech therapy, all with the goal of maximizing potential outcomes. But a general treatment, I mean, wow, that's really exciting. Even if it's not curative, it's a marvelous thing.
Yeah.
And in the same issue of Pediatrics, there's a call from a leading cerebral palsy researcher, Dr. Arav Mauthan, to standardize the diagnosis of cerebral palsy. So this also is important. You know, we toss around terms like cerebral palsy, but it means a different thing for each different child. You know, the same thing as autism. So there are essentially individualized aspects of each child's situation, right?
Right.
And so at least, this leading researcher has suggested that we go to a more standardized situation. So essentially we understand each other when we talk to each other about what a child's situation is. And this approach is something that our beloved Delaware pediatric neurologist, Dr. Chuck Bean, has been talking about really for years.
Just last month at our big Wilmington Newcastle Pediatric Association, he lamented the lack of definition. So on another topic, Maddie, did you know that more children in the United States died from influenza this year, a total of 216, than in any year since the swine flu epidemic of 2009? And remember last year on the podcast, we discussed a recent study that found that outpatient pediatricians rarely follow the guidelines for influenza antiviral treatment that is given by the Academy of Pediatrics, including more testing and treating kids, especially under age 5, and those with underlying conditions that are in higher risk. So guess what? Another study shows that as well as outpatient pediatricians, children's hospitals inpatient themselves do not follow these guidelines. A study in pediatrics in April reported that among pediatricians working in children's hospitals, only 49% would treat a patient with Tamiflu if they were hospitalized with influenza and were eligible based on the guidelines. It's more likely that a pediatric infectious disease specialist would treat. That's about 71%. But only about 41% of the pediatric hospitalists who are making most of these decisions would treat according to the AAP guidelines. And I did get a chance to see the CHOP, Children's Hospital Philadelphia ER guidelines on this topic for outpatient ER visits. And their guidelines indicate that if a child comes in with a new fever and a cough over just age 2 and low risk in the ER, they do not test at all for flu. There's an option to treat between 1 and 2, and flu testing is only automatic if the patient is under 1. And their guidelines indicate that they are only to treat children who test positive for flu with an antiviral if they're under 1, and are not to treat children once they're 2 years of age unless there's risk factors. And of course, these are just guidelines. The ER doc can use their judgment. I had a case, I think maybe I mentioned last time, a mom with a 2.5-year-old who went to one of these ERs and they refused to test, and the child did have flu, and the other 3 siblings got flu. When he came to me on Monday, it was too late to treat the first one. Mom was not happy.
Yeah.
And I do think the guidelines at the Delaware Nemours ER is likely about similar. And again, it's worthwhile to mention that ERs are high population density. They deal with huge numbers of sick patients during the flu season, especially at the height of the season. And it's challenging to test and treat all those for flu. But it just gets to the point, and multiple studies show that we need a randomized trial that explores the safety and efficacy of the use of these flu antivirals in pediatric patients. And then there's another new flu conundrum. Now there's new home flu tests. Have you had patients getting these home flu tests?
1 or 2, I think.
Yeah, well, it's going to get more.
Yeah.
And if a parent calls the office and said, my child has a fever and is coughing, just started yesterday, they tested positive for flu, can you just call us in the generic Tamiflu? And my first thought is, well, no, we should see that patient. We should listen to the lungs, examine in the office. There could be other things involved. But I'm sure they'll find somebody by phone who will call it in a teledoc. So I don't know about you, if you're going to treat them by phone or not. But it's something that's just going to get bigger and bigger.
I'm always leery of something that's kind of multifaceted like the flu, as opposed to like a conjunctivitis, in terms of treating it over the phone, because although it's not incredibly common that somebody has a concomitant pneumonia
or wheezing
or ear infection, it's also not uncommon. So it's to me it's much better to put my stethoscope on somebody and feel comfortable with the fact that we're doing everything we can than just to shoot from the hip and say, oh, then you have a positive flu test, here's your Tamiflu.
Right. Amen.
It's just anyway, so did you know that home nasal flu vaccine will soon be available? Yeah, becoming this fall.
I forgot.
Something
I think
else.
Someone said that in one of the talks that this fall.
Yeah.
Home
flu nasal vaccines, right? It's approved for ages 2 and up. It must be prescribed by a medical provider, but parents can then pick it up from the pharmacy and give it to their child at home. Nasal flu vaccines have always been a nice alternative, especially for needle-phobic kids, which account for about 15% of our population. This option of home administration could really be a game changer. And although we talk about the potential use of antivirals to treat the flu, all pediatricians know that the key is to prevent the influenza through vaccination, despite the fact that the protection from the yearly flu vaccine is not perfect. However, the more children who are vaccinated, the less likely their mum-mums and pop-ups may die from the flu, right? But of course, more home flu vaccines means less visits for us, but this is well worth it. I mean, this is a sacrifice I think all of us are more than willing to make in terms of our patient populations.
Yep.
Another condition in the news is vitiligo. And vitiligo is the progressive depigmenting skin condition that can affect about 2% of kids and which peaks in early childhood. There was a nice review of the current treatment options in JAMA Dermatology by Reinhard Yuval. A key aspect of this review is the fact that vitiligo can cause a lot of heartache in kids. Teasing, bullying, consequent low self-esteem. Early treatment is critical. If treatment is started within the first 6 months of the disease, about half the kids will have long-term clearance.
I did not know that.
I did not know that, and this is astoundingly helpful to us, right? In 2021, the topical JAK inhibitor, ruxolitinib, I have a hard time pronouncing that, Opzelura, boy, I have a hard time pronouncing the brand name, right? Was approved for use in kids ages 12 and over, and it's currently in phase 3 testing for kids 2 to 11, which is going to be even more important. Other treatments for vitiligo include topical calcineurin inhibitors like tacrolimus and pimecrolimus, which we have discussed when we have talked about atopic dermatitis or eczema in the past. Stronger topical steroids and phototherapy are also mainstays of treatment. Pediatric providers need to be vigilant in recognizing and treating, or in most cases referring, children with vitiligo to a dermatologist as soon as possible.
Okay, Matt, let's talk about one of your least favorite subjects, television shows. I'm so excited. Specifically, let's talk about medical shows, which honestly, typically, really kind of suck, these medical shows, in terms of showing the real practice of medicine. Yes, I think a lot of us loved St. Elsewhere and MASH and laughed a little at Scrubs, but the medicine part of these shows is almost always ridiculous. But, Maddie, if you only watch one medical show in your life, make it The Pit, where the whole season takes place hour by hour during one shift in a busy urban Pittsburgh emergency room. Oh, and the pediatric cases are awesome. Okay, spoiler alert. Don't listen if you're going to watch this for sure, but here's some of the cases. Child cannabis gummy ingestion, imperforate hymen, infant hair tourniquet, topical heavy metal poisoning, a case of vaccine-preventable disease in a non-vaxxer family who were refusing treatment in this critically ill kid in the ER while they were doing research on their phone while their child is kind of dying about what to do. You should watch it, Maddie. I know that's not your thing, but I'm going to quiz you next episode. I promise you, you'll be like, oh, yeah, this is good.
I'll consider it, man. I'll let you know. So another interesting paper from Pediatrics this year was on the topic of, quote, single bruise, unquote, characteristics associated with abusive versus accidental injury. So this is really important. The authors created a protocol to look at specific findings that, if there's a single bruise on a child, should make you consider that it is possibly from intentionally inflicted injury. So there's a mnemonic for this, and it's actually very helpful. The mnemonic is 10 for faces P. So the 10, T-E-N, represents a bruise on the torso, ears, or neck. The 4 indicates a child under 4 months old. The faces, F-A-C-E-S, stands for injury to the frenulum, angle of the jaw, cheeks, eyelids, or subconjunctiva. The final P is for pattern bruising, such as happens when a slap, a belt, or a cord is used to strike somebody. So again, this is the 10-4 faces P. This rule for assessing the potential that a child has been abused if they have a single bruise has an 81% sensitivity and an 87.6% specificity for abuse. And this is from a single bruise.
Right.
Wow, that's super helpful.
That really is helpful. And it also has a helpful poster if you go on, even just Google it and find it. So I copied that, printed that poster, and I put it on my wall in the office just to keep reminding me to think of this, especially when you have a single bruise. Another study published in JAMA Pediatrics last fall looked at the consumption of 100% fruit juice and how it impacted body weight in children and adults. This was a systemic review and meta-analysis that demonstrated that even a single serving per day of any 100% fruit juice is still too much. It increases BMI.
Yeah, we've known for years that drinks like Kool-Aid and Punch are loaded with extra sugar, with fructose being the worst. But in 100% fruit juice, which has, quote, no added sugar, unquote, it's usually from concentrate. And this concentrate removes any pulp and fiber and skin and is marketed as healthy, but it is not.
Nope.
What is healthy, and we've been kind of lauding this for years, is whole fruit, which means the flesh and the skin and the pulp. These natural components slow down the absorption of all the sugar in the food. 100% fruit juice is just not healthy for kids. The AAP reports that at 1 to 3 years old, about 4 ounces a day is the recommended limit, and for 4 to 6-year-olds, up to 6 ounces a day, and then 8 ounces a day max after that. But honestly, we should tell our patients zero 100%
That's the limit.
fruit juice.
Zero.
Yeah.
And we want to point out again that most of these studies were done in university centers, which may not be around that longer as they cut the funding for research. I mean, this affects lives. The United States, again, as Matt said, was a leader in pediatric medical research in saving these lives through vaccines and life-saving medications that we developed. I heard one person say that while people have complained that there's a lot of freeloaders in many things in the back of the bus that the United States is paying for, and these people are not paying their fair share. This ignores the fact that it's a definite advantage when you are driving the bus. The United States has been driving the bus on so many things medically in so many ways, and now the world is scrambling to find an alternative. And I'm not sure we will ever get that back.
Yeah. All right. Another interesting paper was on neonatal ultrasound and radiographic markers of hip dysplasia in young adults. This is from the April 2024 journal Pediatrics. The bottom line is that 8% of female infants with normal hip ultrasounds have radiographic hip dysplasia when they were checked at 18 years of age. This was not found in males. We know that DDH screen is imperfect and that developmental hip dysplasia can start later in life. In addition, a late diagnosis of DDH is a common area of alleged malpractice in pediatrics. So we wanted to highlight that although the AAP recommends a clinical exam and obtaining a hip ultrasound at 4 to 6 weeks of age for babies who are breech in utero, other major pediatric organizations, including Nemours Hospital for Children, which is a world leader in the treatment of hip dysplasia, led by Dr. Mihir Thakur, recommend an additional ultrasound, or AP frog leg, at 6 months of age, and then having one more x-ray at 2 years of age.
And I've started to do that. It's unclear to me whether we should order that additional ultrasound x-ray on everyone or just on the girls. Are you getting that extra 6 months imaging and 2 years yet, Millie?
Some of my partners have started to talk about it, and so I think I am going to adapt that. And again, it does seem to be more specifically important for the girls.
Right. We know it's 6 times more likely.
Yes.
So moving forward, one of the papers I highlighted for Hot Topics this July was on naloxone dispensing from the October 24 issue of Pediatrics. It is the first estimate of national naloxone dispensing in younger age groups. Now, naloxone prescribing to treat potential opioid overdoses went up 669% between 2017 and 2022. And prescribing by pediatricians went up 991%. But even with all of that 991%, pediatricians still make up only 5.6% of all youth naloxone prescribers, trailing behind nurse practitioners, physician assistants, surgical specialists, and family medicine doctors, and only ahead of dentists and pharmacists. There's a nice commentary from Ignite at Nationwide Children's in this issue, basically stating that we pediatricians should do a better job when considering universal naloxone prescribing. So intranasal naloxone can reverse opioid overdoses. It's safe in infants and in children and in teens. It can prevent youth opioid deaths, which tragically have increased 30-fold since 2013, most particularly in the 15 to 19-year-old age group. Most of the victims have a bystander present when they die, but most of these bystanders are unable to do anything to help the situation. Only 30% of those who died received naloxone from anyone. And even teenagers who go to the ER with an opioid overdose rarely are given a prescription for naloxone when they're discharged. So the author suggests that we should use the phrase, "May I speak to you about ways of keeping your family safe from overdose," when discussing possible naloxone with families in our office. I mean, 40% of opioid deaths and use happen in the home. So since reviewing this article, I am mentioning naloxone to teens and families more often, especially during high school and pre-college well visits, and talking about access to it, whether by prescription or over the counter. It's sometimes cheaper over the counter. It's about $50. And basically, if someone is responsive in blue with small pupils, if you can see them, you can call 911, but you just open the package and squirt 4 milligrams into one of their nostrils. It can be repeated again in 2 to 3 minutes until the EMS responders get there. This delivery system is pretty much exactly like the new intranasal epinephrine, which is looking to replace the needle EpiPen type things. And the intranasal is called Neffy. The dose is 2 milligrams for over 66 pounds and now available for 1 milligram dosing from 33 to 65 pounds. The nice thing is it lasts in stable form for years, over 2 years, I think almost 2.5 years. You don't have to keep giving it every year. It's okay in the heat, so if you leave it in the glove compartment, it still is good. And I think it will become a game changer. Anybody asked about Neffy yet? I've prescribed it a couple times.
Yeah, they've started to ask about it, and I'm always leery about prescribing until I know what their insurance looks like.
Yeah, because it's hard to get it through.
Yeah. So, as an aside, you mentioned that we pediatricians trail behind nurse practitioners and physician assistants in the prescribing of intranasal naloxone. There was a large Vizient survey actually, published this month that indicated that non-physician clinicians now make up 40% of the U.S. healthcare clinician workforce and will soon constitute the majority of healthcare clinical providers. This trend is largely occurring in primary care. Now, we both already know this, and we both have outstanding nurse practitioners and physician's assistants who work with us. Nonetheless, this is a real sea change in primary care, and it appears that our healthcare system will eventually become more like the British model, where there are fewer pediatricians who kind of work as supervisors for general primary care providers when it comes to pediatric concerns.
And the New England Journal of Medicine this week had an article by Song et al. That laments that primary care has gone from a common good to a commodity, driven by direct primary care, DPCs, and concierge practices, often backed by private equity. So more primary care docs are seeing fewer patients each, and mostly just those who can afford the large retainer fees. So we're moving towards a two-tiered system. But on the other hand, again, this is mostly happening with adult docs, but getting into pediatrics, these docs would say they're taking back primary care and giving their patients the full attention they need. So just double sigh.
Yeah.
I don't know where we're going. Another change in practice involves access to information. It's necessary and responsible for practitioners to have the ability to use up-to-date information in such a rapidly changing medical world. And many of us get this information from software resources. I think one of the more popular is UpToDate. And let me just say, podcast pediatricians have no financial connection to UpToDate. But at my reunion last month, I asked my colleagues in all different specialties, surgery, primary care, pediatric adults, if they use this, and every single one of them used it all the time. I've also heard some bigger medical organizations, and mostly from nurse practitioners and our PAs, but even docs, that are now limiting access to some of these resources because they're too expensive. I understand it could be expensive, but it's money well spent. It's priceless. From a patient care point of view, and from a malpractice point of view, it's ridiculous not to give these tools to us physicians. There's just too much change in medicine not to be able to have this at our fingertips. And not providing it is is crazy, especially, honestly, our non-physician providers. We love our MPs, our PAs. We have said over the years that some of their training programs were not as complete as we would have liked, especially during the pandemic. And these kind of programs put them in a position to utilize information like we do and get to the best care for children.
Yeah, I agree. The discussion on whether or not we should cover these fees for up to date in our practice amongst the providers was very short. It's like, yes,
us too,
unequivocally.
And the whole point about some of them can share,
right?
Thing, that's unethical too, because you can use this to get CME credits,
right?
So you can't do that.
I'll tell you, I mean, even
you can't do that.
I think you do this as well, but even in what are common bread and butter things for us, asthma, UTIs, etc. I still, if it's been a little bit, will check the most recent recommendations, and oftentimes they don't change, but every once in a while there's a little twist. And golly, like, we want to stay on top of what's most useful at this minute.
And then some of the non-common things that, like, if we're in the room, I'll say, wait a minute, I'll just come right back. And I run out and I get on Up to Date and I look it up. Sometimes they have great things to print out to give to the families too. So I use it all the time.
It's not uncommon, and I'll share that.
All the time.
And I'll even share the text written for providers with parents who are that interested in it.
I hope they appreciate they have a provider that says, I'm not sure, and I'm going to find out right now.
Exactly. Yeah. So another recent study considers the use of antibiotics in early childhood and the effect of this on chronic pediatric conditions. So this is really fascinating. This article was from Bayer et al. From Rutgers University and was published in the Journal of Infectious Disease last month. And yes, Rob, did you catch that? Rutgers, Jersey. Yes, Jersey rules. Long Island rules. Yeah. We've heard over the years about potential connections between the use of antibiotics early in life and changes that this antibiotic exposure can cause in a patient's microbiome, and possible links to an increased rate of chronic diseases. Studies have implicated this phenomenon in everything from asthma to environmental allergies and food allergies to even things like ADHD and autism and autoimmune issues like type 1 diabetes and JIA and celiac disease. The results of this study, though, are significant because it involved reviewing information from over 1 million kids over the span of 20 years. This was possible by using an excellent database from England and a technique using sibling match controls in order to decrease any compounding variables of genetics and environment. The researchers looked not only at antibiotic exposure, but also at how many different courses of antibiotics were given and of what type of antibiotics. This is important since it's known that different types of antibiotics affect microbiomes to a greater extent than others. For instance, macrolide antibiotics change microbiomes to a much greater extent than penicillins do. Cephalosporins are kind of in the middle.
I had not known that.
I did not either.
I thought you did. Okay.
Maybe I did.
Okay. I had not known that the macrolides, the azithromycins, even the cephalosporins are worse for your microbiome.
Yeah. Wow. I mean, this is just really important stuff, right?
Yeah.
Why would microbiome changes cause chronic diseases, you ask? The mechanism is presumed to be a disruption of the human microbiome, which is referred to as dysbiosis. So dysbiosis refers to an imbalance in the microbial community or the microbiota within the body, often disrupting the natural balance of beneficial and potentially harmful microorganisms. So the balance gets shifted. Apparently, when this occurs in young children, it may affect the normal development of both immune system and of the brain's frontal cortex and of the amygdala and their gene expressions. Traditionally, we think that the concept of antibiotic stewardship as being an attempt to decrease the antibiotic resistance to germs. So, the big hospitals have departments for this. But this topic of the effect on the microbiome is a whole different topic of risk for young children receiving antibiotics and a new way to look at antibiotic stewardship. The primary result of this paper was that significant increases in risk for food allergy and for asthma were seen when young children were given antibiotics, and the effect was very dose-related. It was found that if a young child received 5 or more courses of antibiotics, they were at a 50% higher risk for asthma or food allergies. If they received 1 to 2 courses, they were at a 23% higher risk for asthma and food allergies. This is bad news. But the good news was that the researchers did not find a significant association between early exposure to antibiotics with atopic dermatitis or with allergic rhinitis, and nor did they find any association with autoimmune diseases like celiac or inflammatory bowel disease or juvenile arthritis or psoriasis. All this is good news. Even type 1 diabetes, no evidence that there's a link.
They also did not find an association with ADHD or with autism or anxiety. Of course, RFK and the Department of HHS has told us that by November, they will have definitively determined what causes autism.
Wait a minute. I thought it was September.
Oh, maybe. Maybe they're even faster
Ooh, it's
than we
coming even
thought.
faster.
This, of course, after thousands of the world's most brilliant scientists have been investigating this topic for decades and found autism's cause to be extremely complex and multifactorial, with much of it still a bit of a mystery. Autism is extremely complicated, and we know, though, genetics absolutely plays some role, and maybe some the environment. The biggest surprise in the results of this study on early antibiotics was that there was a strong association between intellectual disability and early antibiotic use. This was even more notable because it was even stronger in sibling-matched cohorts, and particularly true when the antibiotics given were cephalosporins and macrolides. And again, they found the more courses of antibiotics, the higher risk of intellectual disability. They cautioned that the total number of these children found to be affected was relatively low, so they cannot validate it yet, but it certainly gives us all some pause. We all try to be careful with antibiotic prescribing in young children. This type of information makes me wonder about some of the other implications of this. Many of the antibiotics prescribed are for ear infections. Should we perhaps be referring infants and young children earlier for tubes if they've already had a couple of courses of antibiotics? Also, in the past year, we've thrown out a lot of azithromycin because we saw so much mycoplasma, and that's kind of scary. And also for pertussis exposure. And with this information, we also need to wonder if we should be concerned about antibiotics in the 3-year-olds, in the 4-year-olds. I know we're talking about the youngest, but maybe there's not one hard cutoff for when the increase for food allergy and asthma is. So reconsidering our practices and making certain that we're making appropriate diagnoses and using antibiotics sparingly and being careful in prescribing macrolides, trying to lean on amoxicillin or Augmentin is the way to go. And again, doing this amoxicillin to labeling, I'll mention later. We've talked about it before. That would help. And one last quick paper, Maddie, highlighted by Samantha Anderer from JAMA Network, that talked about earlier studies not talking about a big rise in Zins, those nicotine patches. Mm-hmm. And there was one study saying, it's not as big a deal. Well, they re-looked at it again from 10th to 12th grade. And no shocker to us, it's a big deal. Almost twice as much of a rise in these years. And these can be hidden in the mouth. The parents don't even know they have them in there. It comes in many flavors. I've been asking about Zins more and more. The college kids, they'll look at me and go, of course we use it. So I don't know about you, but it's scary. The nicotine is so addictive.
Yeah, we really need to be focusing on this more amongst our our older patients.
And big tobacco is making money on it.
Oh yeah,
and it's not regulated.
Yep. So a paper that we want to discuss, and Rob has just been chomping at the bit because he loved this, concerned strabismus and its portrayal in children's films. So first, let's define the term strabismus. So strabismus is a condition where the eyes are not aligned. They're misaligned and don't point in the same direction. This situation occurs when muscles that control eye movement are not working the way they should. With this, an eye may turn inward or outward or upward or downward, while the other eye remains focused on the object.
And horribly, people call this lazy eye.
Yes, which just has its own implications, doesn't it? Unfortunately, many kids with strabismus experience social isolation. They're more stigmatized and they're more bullied, and they experience more school phobia, anxiety, and depression than their peers do. They're even invited to fewer birthday parties than their peers. We also know the enormous influence of media on children. Enormous. And Rob, especially the influence of animated movies. All right? Yes. So this study by Liu et al. Out of the University of Colorado looked at animated children's movies made between 1989 and 2022. These movies were produced by Disney, DreamWorks, and Ghibli Studios. They found that out of the 125 movies they reviewed, there were 46 characters with strabismus. 13 of these 46 characters with strabismus were primary or secondary characters, characters with names, and the other 33 were kind of peripheral characters. The characters with strabismus were portrayed as either stupid, evil, or frightening. And a perfect example of this is Ed the hyena in The Lion King. Ed's the only named character in that movie that can't speak and who is often shown chewing on his own limbs. I remember that guy.
Yep.
He communicates only through manic laughing. In a scene where Scar sings, it's clear from Ed's vacant expression that the lights are not all on upstairs. Yes.
And then there's Hei Hei, the rooster from Moana. The Disney animator who created Hei Hei said they intended for him to be, and I quote, the stupidest character in the history of Disney animation. The point is made in the paper that in animation, physical appearances are designed from scratch. They're completely intentional. Children's media producers should do better, especially Disney. Okay, before the break, one more frightening tidbit. In the Journal of JAMA this month, a modeling was done of the reemergence of vaccine-preventable infectious diseases as a consequence of the declining vaccine rates in this country. As they decrease, it was predicted that once they start going down to 50%, measles and others will become endemic again. If this occurs, the simulation model predicts 51 million measles cases, 9.9 million rubella, 4.3 million polio, 197 diphtheria over the following 25 years, resulting in over 10 million hospitalizations and over 159,000 deaths. In the meantime, right now, pertussis cases are soaring. 2 infants in Louisiana recently died, the first such deaths in 2018, and of course the 3 measles deaths in West Texas. And as a side note, despite some of the current concerns, unless a child is traveling to the endemic area in the third world, or maybe now to West Texas, there's no reason to give an early measles vaccine at 6 months or to give that second dose before age 4, because smaller studies show that if you do this, that at the end of all the vaccines, the levels of antibodies that protect against measles are a little bit lower than if you go to the standard 1 to 4. And I know, Matt, you've had this in your office all the time. Should we get measles at 6 months? Should we get it early at 2 years? And so we won't refuse if they insist, but it doesn't make sense until things change a lot to do that now. All right, we'll be back at the break. I got to pee. Okay, we are back, and I thought we would return to some of the pearls from last Disney's meeting provided to us by Dr. Brian Alverson. In the last episode, we discussed the use of honey for coughing and diluted apple juice for gastroenteritis, and even about rectal ibuprofen, and Matt tells me he's used all 3 of these on himself multiple times.
Woohoo!
And he thinks they work.
I won't tell you which was my favorite.
Dr. Alverson also has been a member of the group that creates the AAP guidelines for addressing UTIs, and he gave a really nice overview of that. He started by noting that about 1% of infants, whether healthy or sick with a fever, will have asymptomatic bacteriuria if they are screened with urine testing. And that, while UTI guidelines often use evidence of an inflammatory response in decision-making, like the presence of white blood cells in the urine, to help make the diagnosis of a UTI, he mentioned that some bacteria that cause UTIs, like enterococci, are well known to not always cause that inflammatory response. Multiple types of bacteria can convert nitrates, a naturally occurring substance in the urine, into nitrites, and the presence of nitrites has traditionally been seen as a strong indicator for a bacterial infection. But Dr. Alverson noted that studies do not support using nitrites in the urine as a reliable marker for diagnosing a UTI. So don't get hung up on nitrates. What you really want to know is whether there are white blood cells in the urine sample. Finding at least 1% leukocytes in the urine of an infant or young child on a dip, or 2+ in an older child, and 10 to 20 white cells per high-powered field is suggestive of a UTI. And even with this, studies have shown, as we said, there could be a UTI without any inflammatory response. And That kind of blows my mind. Oh, this is M.
No, that's not the point. This isn't M. This is still U, I believe.
No,
But
well-
you said finding at least 1% leukocytes
Oh,
as
okay.
opposed to 1 plus.
Okay.
So go back to the beginning of that paragraph.
What you really want to know is whether there are white blood cells present in the urine sample. Finding at least 1 plus leukocytes in the urine of an infant or child, or 2 plus in the urine of an older child on your urine dip, and if you have a microscope, 10 to 20 white cells per 10 to 20 white cells per high-powered field, is suggestive of a UTI. But even with this, again, studies show that there could be a urinary tract infection without any inflammatory response at all, which really kind of blows my mind. Much of this information is based on the work of Dr. Nader Sheikh, a graduate of our residency program in 2000, who spoke at R.Y. Warren's All Alumni Pearls seminar last November. And for those of you in the area, don't forget to register for this year's R.Y. Warren on Wednesday, November 12th, in person only. It'll have great pearls from all alumni, plus 2 masters in pediatric lectures from neurologist Chuck Bean, who we mentioned, and hospitalist extraordinaire Dr. Jeff Malatak, and a great alumni reception afterwards. So, Maddie, I expect you to be there that Wednesday.
I'll do my best, Rob.
Thank you.
So a clinician might reasonably ponder treating a patient empirically with antibiotics while waiting for the results of a urine culture, even if there are no WBCs on the urine dipstick, or even if no WBCs on a microscopic UA, if they are highly suspicious of a urinary tract
Again,
infection.
so negative leukocytes, negative nitrates.
Mhm. Yep. Starting treatment might still be warranted based on the history and the physical exam. Dr. Alverson discussed the controversy that surrounds the definition of a UTI that has traditionally been based on the number of colony-forming units that grow in culture. He confirmed that the standards that existed when Rob and I trained are still legitimate. That is, in general, 10,000 CFUs for urines obtained by sterile catheterization and 100,000 CFUs for those obtained by clean catch. The duration of antibiotic treatment for a routine UTI, that is a cystitis or a bladder infection, is 3 to 5 days if the child did not have a fever and is over 1 year old. The length of treatment is 5 to 7 days for a pyelonephritis, that is a kidney infection, and 10 to 14 days for a complicated pyelonephritis. And what about imaging to determine if there's been renal scarring with this infection?
Oh boy, that's the controversy, the imaging. And urologists feel we are not doing enough imaging anymore because they changed the guidelines. But Dr. Alverson referenced a number of long-term studies done in young adults with chronic renal failure. And obviously that's what we're trying to avoid is renal failure. And these studies showed that chronic renal failure due to scarring from previous urinary tract infections is very uncommon. Even though some renal scarring is caused by infection and some renal scarring can be caused by urinary reflux, most of the scarring is by some entity that is unknown at this time. Some may be genetically predisposed to renal scarring. The issue is still mostly unclear. So we do not do VCUGs as much as we used to anymore. And if we do obtain an ultrasound in a young girl with a second UTI or in a febrile UTI or in a boy with his first UTI, it's more often to check for any congenital anomalies of the kidneys, ureters, or bladder. And remember, a normal renal ultrasound does not rule out vesicular-ureteral reflux. Even a patient with high-grade reflux can still have a normal kidney and bladder ultrasound. And Maddie, remember when we used to do antibiotics prophylaxis to prevent UTIs in kids? A lot of it every day. Dr. Alverson did the math that shows that this practice may do more harm than good, especially as it pertains to development of antibiotic resistance, and that prophylactic antibiotics really does nothing to prevent renal scarring. And not to mention its lack of effect on preventing chronic renal failure, which is why we don't do it anymore. And now, based on the study we just talked about, we have to consider risks of future asthma, food allergy, and intellectual disability.
Yes.
All those kids we used to give daily antibiotics to. I'm glad we're not doing that anymore.
Yeah, me too. So the first-line antibiotic treatment these days for urinary tract infections is usually cephalexin, also known as Keflex, old school antibiotic, right? And not necessarily amoxicillin clavulenate, also known as Augmentin. Rob, do you remember when the trend was to give a third-generation oral cephalosporin?
Oh, yes.
Ceftonir, right?
Yes. That was first.
Yeah,
Omnicef,
always.
MSF for everything,
Yes,
right?
yes. And you would use that even for a pylo, like
Ceftonir.
outpatient.
Yep.
Absolutely. Also, less trimethoprim sulfamethoxazole, also known as Bactrim, that's been used as well. Although all of these can have their place. In adults, nitrofurantoin, a.k.a. macrobid, is often used. And beyond that, Bactrim and Cipro are often used. As a reminder to all practitioners out there, please, especially you medical aid unit folks, always get a culture and sensitivity of treating for a UTI. In summary, Dr. Alverson suggests that the diagnosis of UTI generally requires urine demonstrating white blood cells unless an infant or child has classic symptoms of UTI, in which case, even if the urine sample does not reveal white blood cells, you may still want to treat them anyway while you await the urine results.
And of course, using bagged urine samples for urine culture is bad.
Bad.
Very bad.
Bad.
With the caveat that if you're screening for leukocytes and you get a bag specimen that is completely normal without leukocytes and you don't have a high suspicion for UTIs, you might be able to avoid catheterizing that child. But remember, don't send a bag urine for culture. Dr. Alverson reiterated that renal scarring is a real thing, but it's just not clear how we can prevent it.
Dr. Alverson's third talk was on bronchiolitis. As he mentioned, the approach to these young wheezing kids really varies from institution to institution. Some facilities get more chest x-rays or give a trial of albuterol or even give antibiotics, and some do none of these things. How do you even define bronchiolitis or wheezing episodes caused by viruses like RSV? As Dr. Youssef from our last episode described, you cannot decide that any infant or young toddler with wheezing has bronchiolitis per se, since they may have asthma as the source of their wheezing, and asthma can occur at any age. At least there's a decent consensus backed up by studies that oral steroids for children with bronchiolitis is not indicated. There are dangers in overusing oral steroids. Well, how about giving albuterol in the case of bronchiolitis? Studies show that its use does not seem to reduce the likelihood of hospitalization, nor does it reduce the length of hospitalization. Although albuterol is safe under almost any circumstances, it can be an unpleasant experience for a young child. It can cause racing heart rates, jitteriness, and sweating. It's not something we should reach for unless we have a specific reason, like family history of asthma, or perhaps prior episodes of wheezing, or even, Rob, my favorite, which is I'll trial it. If there's a dramatic change in the patient, then I'm starting to think more of a asthmatic type situation than bronchiolitis per se.
And that change may not be change in wheezing; it's just better air movement. Right? I can
Aeration
hear it better,
is the thing,
and that's the thing you can't really do.
It's hard to
on
quantify
telemedicine
that.
either. Yes. So Dr. Alverson also touched on the use of high-flow nasal cannula, which excited many of the pediatric hospitalists in the audience. But this doesn't seem to shorten the length of hospital stay for those who are admitted, and there's not been any study showing that it has a great benefit. What does help, and we all know this, is suctioning the mucus. Matt, how many times have you had a family go to the ER with a young infant, with a toddler, with wheezing and mucus, and their mom reports later that as soon as they got to the ER, they were suctioned with wall suction, and a lot of snot came out, and the kid looked great.
It just makes perfect sense,
Yes.
doesn't it? I mean, you've got gunk in this tube you're trying to transmit air back and forth through. You suck the gunk out, and the child seems better.
So his final recommendation is for any of us who go to a baby shower. A nose-Frida type of device never fails to be the best gift that a mom and dad can receive to help them suction out the snot.
Indeed. The idea is a little off-putting, but it really can work, right?
I got you
an
outfit. I got you a toy. I got you a nasal sucker.
I got you a snot sucker.
Yeah, but they'll love it. Okay, Maddie, I think that's all we got, except to say that the Philadelphia Phillies are in first place.
Yes, and that is good news.
It's good news, beating up on the worst teams.
Oh, man.
I think the Rockies have the worst record since 1895, but a good team beats bad teams, right?
Wouldn't it be sweet to capture a World Series and a Lombardi in the same year?
It would be sweet. Don't jinx it, okay? But the other part for Philly fans is like, even if the Phillies fall short, we just won a Super Bowl. I mean, like, we can roll on that.
We never think about it.
We can roll on that for a while. Even the New York Knicks, my late father's favorite team, are making some noise.
They are making a little bit noise. All right, so let's wrap this up, Robbo. Say goodnight.
Good night, Moon. And see some of you at the Hot Topics Pediatrics Disney in July, including a great hot controversy debate, surgery versus GLP-1s for severe morbid obesity in older teens. Last thing to say, bye.
Bye.
Podcast Pediatricians Productions. All rights reserved.